Patients suffering from severe generalized anxiety disorder rarely schedule primary care appointments to discuss anxiety. Instead, these patients arrive at the clinic physically overwhelmed by an unseen stressor, manifesting as tangible, localized pain. Rather than reporting psychological distress, these patients present with a specific cluster of persistent physical complaints. Gastrointestinal distress is the most frequent initial symptom that misdirects clinical focus toward a physical pathology. Chronic, unexplainable fatigue serves as the second most common masking symptom in both adults and adolescents. Tension headaches and persistent insomnia represent the final components of the typical primary care presentation. To effectively treat these patients, clinicians must trace these isolated somatic markers back to their neurological origin. This requires defining the cognitive driver, operationalizing the diagnostic criteria, and establishing a clear referral pathway. Failing to look past the physical symptoms leads to patient recidivism, as treating the somatic manifestation without addressing the psychiatric root leaves the underlying pathology intact. The underlying mechanism of GAD is a continuous, hard-to-quiet cognitive worry loop. This loop spans multiple domains, including finances, family, and future events, rather than a single isolated phobia. This diagram shows the origin of the cognitive load within the central nervous system, specifically the prefrontal cortex and amygdala. Chronic activation of this loop floods the autonomic nervous system with descending distress signals. The gut reacts directly to this neurological cascade, while simultaneous signals target the skeletal muscle groups of the neck, back, and shoulders. These specific muscle pathways create the tension headaches and stiffness the patient reports, while disruptive signals in the sleep centers produce clinical insomnia. This neurochemical disruption prevents restorative sleep, resulting in severe daytime fatigue. This differs from a normal acute stress response, which dissipates rapidly once the immediate external stressor is removed. In GAD, the loop self-sustains, even in the total absence of an immediate external threat. Somatic complaints in GAD patients function as the direct physical output of an overloaded neurological circuit. How can a primary care provider differentiate normal life stress from a diagnosable psychiatric disorder during a brief intake? We use the DSM-5 criteria as a strict mathematical filter to ensure diagnostic accuracy. The first requirement is temporal. The excessive worry must persist for at least 6 months. This worry must be present on most days during this period, not just intermittently. The worry must also be multi-domain. Fixation on a single issue does not meet the diagnostic threshold for GAD. Once the timeline is established, the clinician must confirm the physical symptom threshold. We look for the physical markers: muscle tension, sleep disturbance, fatigue, irritability, and GI distress. At least 3 of these distinct somatic symptoms must accompany the cognitive worry to cross the diagnostic threshold. Clinicians often misclassify patients meeting these criteria as natural worriers. Instead, the condition should be viewed as a measurable pathological state that requires medical intervention. Adherence to both the 6-month temporal threshold and the 3-symptom somatic threshold prevents misclassifying normal life adversity as a psychiatric pathology. When the DSM-5 threshold is crossed, the focus shifts to identifying evidence-based interventions. This clinical pathway for GAD is bifurcated into pharmacology and psychotherapy. SSRIs, or selective serotonin reuptake inhibitors, are the established baseline for pharmacological treatment. These medications stabilize the neurochemical baseline, reducing the severity of the physiological cascade. On the psychotherapy branch, cognitive behavioral therapy, or CBT, remains the gold standard intervention. CBT works by identifying and restructuring the distorted thought patterns that drive the worry loop. Acceptance and commitment therapy, or ACT, provides a highly effective alternative. ACT focuses on changing the patient's relationship to their anxiety, reducing the struggle against the loop. While pharmacology reduces acute distress, psychotherapy is required to dismantle the underlying cognitive pathology and prevent relapse. An accurate diagnosis only benefits the patient if there is an accessible referral pathway for treatment. Historically, geography and cost have been the primary barriers to receiving these therapies. Coping and Healing Counseling, or CHC, provides a targeted referral solution for clinicians in Georgia. Their workforce includes over 15 licensed therapists, including LCSWs, LPCs, and LMFTs, all deeply trained in these specific modalities. This map shows the CHC telehealth model, which serves patients across all 159 Georgia counties. This system provides care for individuals, couples, and families, including teens aged 13 and up. CHC is in-network for Aetna, Cigna, BCBS, United Healthcare, and Humana, with commercial copays typically ranging from $10 to $40 per session. For the Medicaid population, CHC provides coverage with a $0 copay. Removing these financial friction points increases the likelihood of a patient following through on a primary care referral. Clinics can integrate CHC into their referral systems by utilizing these contact protocols. Screen for the somatic markers, apply the DSM-5 timeline, and route your patients to accessible telehealth therapy to break the anxiety loop.